Stop what you are doing right now and listen to me carefully, because what I am about to share with you in the next few minutes could be one of the most important things you hear this entire year, especially if you are over the age of 60 and you are currently taking Amlodipine, Losartan, or Lisinopril for your blood pressure. I want you to stay with me until the very end, because the information I am going to walk you through today is not something that comes up in a standard 10-minute doctor's appointment, and it is absolutely not something printed on the little sheet of paper that comes stapled to your prescription bag. My name is Dr. William, and for the past 26 years, I have worked directly with older adults managing cardiovascular conditions, hypertension, and the long-term consequences of chronic medication use. And what I have witnessed in my clinic, confirmed again and again in the research I study every single week, is that millions of seniors are taking these 3 specific blood pressure medications every day without knowing several things that could genuinely change the trajectory of their health. I am not here to tell you to stop your medication. Please understand that clearly. What I am here to do is give you the complete picture that your pharmacist does not have time to explain, that your cardiologist assumes you already know, and that somehow never makes it into the conversation you actually have with your doctor. Because when you walk out of that office with a prescription, you deserve to understand exactly what is happening inside your body, not just that your numbers are going down on a chart. Let me start by telling you about a patient of mine, a 71-year-old retired school principal named Carol from Phoenix, Arizona. Carol had been taking Lisinopril for 9 years when she first came to see me. She was not there because of her blood pressure, which was actually well controlled. She was there because for the past 2 years she had been experiencing a dry, persistent cough that would not go away, episodes of dizziness when she stood up from her chair, and a fatigue so heavy that she described it to me as feeling like she was trying to walk through wet concrete every single morning. Her previous doctor had run tests for respiratory infections, for thyroid issues, even for early signs of heart failure. Everything came back normal. Nobody had connected what was happening to Carol directly to the medication she had been faithfully taking every day for nearly a decade. When I reviewed her complete medication history and cross-referenced it with what the research tells us about long-term ACE inhibitor use in adults over 65, everything became clear. Carol was not sick with something new. Her body was reacting in perfectly documented, clinically understood ways to a medication that had been in her system for 9 years. Within 4 months of working together to adjust her approach, Carol told me the wet concrete feeling was gone, she was carrying her own groceries again, and the cough that no specialist could explain had disappeared completely. That is why I am making this video today. Let us talk about Lisinopril first, because it is one of the most prescribed medications in the entire United States, and the number of seniors taking it is staggering. Lisinopril belongs to a class of drugs called ACE inhibitors, which stands for angiotensin-converting enzyme inhibitors. The way it works is by blocking a specific enzyme in your body that normally causes your blood vessels to tighten. When you block that enzyme, the vessels relax and your blood pressure comes down. It is a genuinely effective mechanism, and for many people it is life-saving. But here is what the research has been quietly documenting for over a decade that most patients are never told directly. In adults over the age of 60, the ACE enzyme that Lisinopril targets is not only involved in blood pressure regulation, it also plays a role in potassium balance in your kidneys, in your body's production of a substance called bradykinin, and in how efficiently your respiratory system manages fluid and irritants in the airway lining. When you block the ACE enzyme, especially over months and years, bradykinin begins to accumulate in your system. And elevated bradykinin in older adults is the direct, documented, clinically confirmed cause of that dry, irritating cough that affects somewhere between 15 and 35% of people taking this medication. If you are on Lisinopril and you have a cough you cannot explain, I want you to write that down right now. Not because you should panic, but because that connection is something you have the right to bring to your doctor as an informed person. Beyond the cough, long-term ACE inhibitor use in older adults has been associated in multiple large-scale studies with a condition called orthostatic hypotension, which is the medical term for that sudden dizziness or lightheadedness you feel when you stand up too quickly. A study published in the Journal of the American Geriatric Society followed over 8,400 adults aged 65 and older for a period of 7 years and found that those on long-term ACE inhibitor therapy had a significantly elevated risk of fall-related injuries directly linked to this drop in blood pressure upon standing. For a 70-year-old woman, a fall is not a minor inconvenience. It is a potential fracture, a hospitalization, and sometimes the beginning of a very rapid physical decline. This is not a reason to stop your medication. It is a reason to know the signs, to stand up slowly, to hold on to something for the first few seconds, and to have a direct conversation with your physician about whether orthostatic hypotension has ever been evaluated in your specific case. Now let us move to Losartan, which is another extraordinarily common blood pressure medication, and one that works through a slightly different mechanism. Losartan belongs to a class called ARBs, or angiotensin receptor blockers. Instead of blocking the enzyme that produces the vessel tightening hormone, Losartan blocks the receptor that the hormone tries to attach to. Think of it this way. If angiotensin is a key, Losartan changes the lock so the key cannot get in. The blood vessels do not receive the signal to tighten, and blood pressure comes down. It is elegant pharmacology, and again, for many people it is genuinely effective and necessary. But what many seniors on Losartan are not told involves what this medication does to your kidneys over time, particularly in the context of aging kidneys that are already working harder than they were 20 years ago. Here's a fact that I want you to understand clearly. After the age of 60, the average person's kidney filtration capacity decreases by approximately 1% per year. By the time you are 70, your kidneys may be operating at only 70 to 75% of the capacity they had when you were 50. This is normal aging. But when you add an ARB like Losartan to kidneys that are already operating at reduced capacity, the medication can in some cases further reduce blood flow to the kidney tissue itself in a way that, over years, contributes to what clinicians call cardiorenal syndrome or chronic kidney stress. A landmark analysis published in the New England Journal of Medicine reviewing data from over 22,000 patients found that long-term ARB therapy in elderly patients required careful monitoring of kidney function markers, specifically creatinine and eGFR levels, at regular intervals to catch early signs of kidney stress before they became serious problems. I want to ask you something right now, and I want you to answer it honestly. When did your doctor last check your creatinine level and your eGFR? If you are on Losartan and you cannot remember the last time those specific numbers were reviewed, that is a conversation you need to initiate at your very next appointment. You are not being paranoid. You are being an informed patient, which is exactly what you should be. There is another piece of the Losartan picture that almost never comes up in the appointment, and it has to do with potassium. Losartan, like other ARBs, can cause potassium levels in the blood to rise. In younger, healthy individuals, the kidneys handle this efficiently. In older adults with already reduced kidney function, potassium can begin to accumulate, and elevated potassium, a condition called hyperkalemia, is something the heart feels before any other organ in your body. Hyperkalemia can cause muscle weakness, irregular heartbeats, and in severe cases, cardiac events. I had a patient, a 74-year-old retired engineer named George from Tampa, Florida, who had been on Losartan for 6 years when his wife brought him to my office because he had been experiencing what he described as an unusual fluttering in his chest for several weeks. His cardiologist had done an EKG. His primary care doctor had done blood work, but nobody had checked his potassium in over a year. When we ran the panel, his potassium was elevated well beyond the normal range. The culprit was not something he was doing wrong. It was a combination of his aging kidneys, his Losartan, and a healthy diet that included lots of bananas, avocados, and sweet potatoes, all foods high in potassium, all foods we normally celebrate as heart-healthy choices. For George, those foods were working against him in the context of his specific medication. Once we addressed his potassium management, the fluttering in his chest resolved within 3 weeks. George told me at his last visit that he felt like himself again for the first time in months. These are the things that fall through the cracks when information is not communicated completely. Before I continue, if you are finding this information valuable, if you are learning things right now that you wish someone had told you years ago, I want you to take 1 second and subscribe to this channel. Every single week, I bring you research-backed, senior-specific health information that I believe can genuinely protect your independence, your quality of life, and the years ahead of you. 1 click, 1 second. And now let us talk about amlodipine. Amlodipine is a calcium channel blocker, which means it works by preventing calcium from entering the muscle cells of your heart and blood vessel walls. When calcium cannot enter those cells, the muscles cannot contract as forcefully, the vessels relax, and blood pressure comes down. The heart does not have to work quite as hard. For many seniors with hypertension, amlodipine is genuinely one of the better tolerated options available. But there are several things happening in the body of a senior on long-term amlodipine that most people are never told, and I want to walk you through each one carefully. The first is peripheral edema, which is the medical term for fluid accumulation in the lower legs and ankles. Research consistently shows that ankle swelling affects between 8 and 17% of people taking amlodipine, and the rate is significantly higher in adults over 65. The mechanism is straightforward. Amlodipine relaxes the arterial walls of your blood vessels, which is exactly what it is supposed to do, but this relaxation is not perfectly uniform. The venous side of your circulation, the side that brings blood back up from your legs toward your heart, does not receive the same benefit. This creates a pressure imbalance in the capillaries of your lower extremities, where fluid begins to leak out of the blood vessels into the surrounding tissue. The result is swollen ankles and lower legs, particularly by the end of the day, particularly after long periods of sitting or standing. Now, I want to be very clear about something that causes enormous confusion and unnecessary worry. Ankle swelling caused by amlodipine is not the same as ankle swelling caused by heart failure. They can look identical from the outside, but they are completely different in origin and in seriousness. The amlodipine-related swelling is a mechanical consequence of how the drug works, not a sign that your heart is failing. But because patients are not told this clearly, many of them panic when they notice their ankles are puffy, rush to the emergency room, or their cardiologist convinced something is terribly wrong, and then receive an anxious wait and a battery of expensive tests that ultimately confirm their heart function is fine. Knowing the difference, understanding that this swelling is a known and documented side effect of amlodipine and not a cardiac emergency allows you to monitor it calmly and discuss it with your doctor in a scheduled appointment rather than from a hospital bed at 2 a.m. The second thing you should know about long-term amlodipine use involves what the research is increasingly documenting about its effects on gum tissue. I know this sounds unrelated to blood pressure, but stay with me because this is something almost no senior on amlodipine is told, and it genuinely affects quality of life in ways that compound quietly over years. A well-documented side effect of long-term calcium channel blocker use, including amlodipine, is a condition called drug-induced gingival hyperplasia, which essentially means an overgrowth of gum tissue. Studies suggest that this affects approximately 10 to 20% of people on long-term amlodipine therapy. The gums begin to grow over the teeth slowly, so slowly that many patients do not notice it happening. Over time, it can affect how you chew, how you speak, and it can create pockets of tissue where bacteria accumulate, leading to accelerated gum disease. The simple awareness of this potential effect means that you should be telling your dentist that you are on amlodipine at every single cleaning and checkup. Your dentist can monitor for early signs of tissue overgrowth and intervene before it becomes a significant problem. Something as simple as that awareness and that communication between your doctor, your dentist, and you can prevent years of unnecessary dental complications. Now, I want to talk about something that applies to all three of these medications, Lisinopril, Losartan, and Amlodipine, and it is perhaps the most important point in this entire video. I want to talk about what happens when seniors are on these medications long-term and they are not regularly reevaluated for whether the original dose is still appropriate for their current body. Blood pressure management is not a set it and forget it situation, particularly in older adults, and here is why. As we age, our cardiovascular system changes. The elasticity of our blood vessels decreases. Our body's ability to regulate blood pressure in response to position changes, hydration levels, and physical activity becomes less precise. The medications that were calibrated for your body at 62 may be too strong for your body at 71. When a blood pressure medication is too strong for an older body, it does not just lower your numbers a little too far. It actively increases your risk of falling, of experiencing cognitive fog, of feeling persistently tired and unmotivated, and in some research, of contributing to what clinicians call iatrogenic frailty, meaning frailty that was accidentally caused by the very treatment intended to help you. A study published in JAMA Internal Medicine followed over 4,500 older adults on antihypertensive medications and found that those whose medications were actively reviewed and adjusted based on their current health status and blood pressure readings had significantly better outcomes across multiple quality of life measures compared to those whose prescriptions had not been meaningfully reevaluated in over 2 years. The question I want you to carry with you to your next appointment is this: when did we last seriously discuss whether my current dose and my current medication are still the right fit for where my health is today? That single question, asked with the confidence of someone who has done their research, can open a conversation that genuinely changes your trajectory. I also want to address the interaction picture, because seniors taking blood pressure medication are rarely taking only blood pressure medication. The average American over the age of 65 is taking between 4 and 6 prescription medications simultaneously. When Lisinopril, Losartan, or Amlodipine are part of that mix, there are specific interactions that the research flags as particularly important for seniors. Lisinopril interacts significantly with NSAIDs, which are the non-steroidal anti-inflammatory drugs like ibuprofen and naproxen that many seniors take regularly for joint pain and arthritis. Taking NSAIDs alongside Lisinopril can reduce the effectiveness of the blood pressure medication by a clinically meaningful amount, and can also increase the strain on the kidneys. If you are taking Lisinopril and you reach for ibuprofen regularly, that is a pattern your doctor needs to know about. Losartan interacts with potassium supplements and with certain potassium-sparing diuretics in ways that can push potassium levels dangerously high, as I described with George's situation. And amlodipine has a well-documented interaction with grapefruit and grapefruit juice, which I want to take a moment to explain because it surprises so many people. Grapefruit contains compounds called furanocoumarins that inhibit a specific enzyme in your intestinal wall called CYP3A4. This enzyme is responsible for breaking down amlodipine as it enters your bloodstream. When grapefruit blocks that enzyme, your body absorbs significantly more amlodipine than intended, sometimes dramatically more, which means your blood pressure can drop further and more rapidly than your dose was calibrated to produce. For an older adult whose blood pressure regulation is already less precise than it was at 50, a grapefruit-induced spike in amlodipine absorption can cause a dangerous drop in blood pressure, a fall, dizziness, or worse. This is not theoretical. It is a documented pharmacological interaction that every person on amlodipine deserves to be told explicitly. If you drink grapefruit juice in the morning and you take amlodipine, please tell your doctor or pharmacist today. Let me tell you about another patient, a 68-year-old woman named Patricia from Dallas, Texas. Patricia had been on a combination of amlodipine and Losartan for 4 years when she came to me struggling with what she described as a fog over her mind. She could not concentrate the way she used to. Words felt further away. She was forgetting the names of neighbors she had known for 20 years. Her family was quietly beginning to worry about dementia. Her primary doctor had referred her to a neurologist. The neurologist ran cognitive assessments and found her results borderline. But nobody had looked carefully at the combination of her two blood pressure medications and what the research says about blood pressure that is being managed too aggressively in older adults. There is a growing body of research, including findings from the Sprint Mind study and subsequent analyses, that suggests that in certain older adults, particularly those over 70 with specific vascular profiles, pushing blood pressure too low, below certain thresholds, can actually reduce cerebral blood flow enough to affect cognitive function. Patricia's blood pressure was being maintained at levels that were considered excellent by standard guidelines, but her individual brain may have needed slightly higher pressure to maintain adequate perfusion. When we worked with her cardiologist to carefully adjust her medication approach over several months, Patricia's cognitive fog began to lift. She told me 6 months later that she had finished reading a novel for the first time in 2 years and remembered it clearly. Her family called it remarkable. The research calls it optimized individual care. I call it what happens when seniors are treated as individuals rather than as a set of numbers on a chart. I want to spend a moment now on what you can practically do with everything I have just shared, because information without action is just anxiety, and that is not what this video is meant to give you. The first thing I want you to do is write down these 3 questions and bring them to your next appointment with your prescribing physician. First, when did we last evaluate whether my current dose is still appropriate for my current health status? Second, have you ever checked my kidney function markers since I started this medication? And if so, what were the results? Third, are there any interactions between my blood pressure medication and the other prescriptions or supplements I take that I should be aware of? These 3 questions are not confrontational. They are not accusatory. They are the questions of an informed, engaged patient who is taking responsibility for their own care, and any good physician will welcome them. The second thing I want you to do is start paying attention to your body in ways that you can bring as data to your doctor. If you are on Lisinopril, notice whether you have a chronic cough or regularly feel dizzy when you stand. If you are on Losartan, pay attention to whether you notice muscle weakness or irregular heartbeats, and ask your doctor how often your potassium and kidney function should be monitored in your specific case. If you are on Amlodipine, look at your ankles in the evening. Look at your gum tissue the next time you brush your teeth. These are simple observations that cost you nothing but attention, and they can give you and your doctor genuinely useful information. The third thing I want you to understand is that lifestyle factors remain among the most powerful tools available for blood pressure management in seniors, and they work alongside medication, not instead of it. The DASH diet, the dietary approaches to stop hypertension, has been studied more extensively in older adults than almost any other nutritional intervention for blood pressure, and the results consistently show clinically significant reductions in systolic blood pressure with adherence to its principles, reducing sodium, increasing potassium-rich foods within the context of your specific medication, eating more leafy greens, whole grains, low-fat dairy, and lean proteins are not just platitudes. They are measurable interventions that can in some cases allow you and your doctor to discuss whether your medication dose might be carefully reduced over time. Regular physical activity, specifically low-impact aerobic exercise like walking, swimming, or cycling for 30 minutes most days of the week, has been shown in multiple randomized controlled trials to reduce systolic blood pressure by an average of 5 to 8 millimeters of mercury in older adults. That is a meaningful reduction, not a replacement for medication for most people, but a meaningful contribution that your body will thank you for in ways that extend far beyond blood pressure. Sleep quality is another factor that is routinely underestimated in blood pressure management. Multiple studies have now confirmed a bidirectional relationship between sleep disruption, particularly obstructive sleep apnea, which becomes more common with age, and elevated blood pressure. If you are consistently sleeping poorly, if you snore, if your partner has told you that you stop breathing during the night, that deserves a conversation with your doctor independent of your blood pressure medication, because addressing sleep quality can have a meaningful impact on your cardiovascular numbers and on the amount of medication you ultimately need. I want to circle back to something I said near the beginning of this video because I think it is the most important frame for everything I have shared. These medications, Amlodipine, Losartan, Lisinopril, have helped millions of people live longer and avoid strokes and heart attacks that might otherwise have ended or dramatically limited their lives. The research supporting their use is robust, and I am not here to undermine that. What I am here to advocate for is your right as a senior patient to be fully informed about what these medications do inside your body over time, to ask the questions that help your doctor give you individually calibrated care rather than population average care, and to approach your own health as an active participant rather than a passive recipient. The seniors I have seen thrive the most in my 26 years of practice are not the ones who simply comply without question. They are the ones who show up to their appointments with notes, who ask their doctors to explain things twice if needed, who bring their spouse or a trusted family member to help absorb information they might not retain in a stressful clinical environment, who call their pharmacist, because pharmacists are extraordinary and deeply underused resources for medication information, and ask directly whether there is anything they should know about their specific combination of drugs that they might not have been told. Carol, the retired school principal from Phoenix, came back to my office 3 months ago for a check-in. She was 73 years old. She was managing her blood pressure with a medication that was more appropriate for her specific physiology after years of working together to find the right fit. She was walking 2 miles every morning. She had not coughed in over a year. She looked at me from across the desk and said, "Dr. William, I wasted years feeling terrible because nobody gave me the complete picture. I do not want that for you. You have worked too hard, built too much, and loved too many people to spend the years ahead of you feeling like less than you are, simply because information was incomplete." If this video has given you something valuable today, if there is one thing you learned that you are going to bring to your next doctor's appointment, I want you to do 2 things right now. First, subscribe to this channel because every single week I bring you information exactly like this: research-backed, senior-specific, honest, and complete. Second, share this video with one person you care about who is taking blood pressure medication. You do not need to say anything complicated. Just send them the link. Because the conversation this video might start between them and their doctor could change the direction of their health in ways that neither of you can fully predict. Leave me a comment below and tell me which of these 3 medications you or someone you love is currently taking. I read every single comment, and your story helps me understand what topics matter most to this community. This is Dr. William, and your health is the only number that truly matters. I will see you in the next video.